Welcome to the Deep Dive, where we take a stack of compelling sources, distill them, and give you the essential nuggets of knowledge. Today, we're diving into a topic that really challenges our traditional ideas about human lactation. Imagine for a moment breastfeeding without having been pregnant. Sounds almost, well, impossible, doesn't it? But it's not. And this deep dive is custom tailored for you, our dedicated learner, especially as you gear up for your IBCLC exam, our mission to distill the intricate world of induced lactation and relactation, providing you with the essential insights and surprising facts you need to feel confident, well-informed, without feeling overwhelmed.
That's right. In this deep dive, we'll unpack what induced lactation and relactation truly entail. We'll explore the various pharmacologic agents and protocols used to achieve them, and even delve into the fascinating composition of induced milk that's often a point of curiosity and, well, concern. Then we'll bring it all together by applying this knowledge to exam-style questions, helping to solidify your understanding for that crucial certification.
Right, let's unpack this remarkable topic. So let's begin with the foundational definitions. When we talk about these processes, what exactly do we mean by induced lactation?
Okay, so induced lactation refers to the process where a non-puerperal woman, meaning someone who hasn't recently been pregnant or given birth, is stimulated to lactate and breastfeed. It's essentially initiating milk production from like a standing start without the prior physiological priming of pregnancy.
Right, and relactation, how does that differ? Is it a completely different challenge or is there overlap?
That's a great question. Relactation applies to women who have given birth previously. Maybe they didn't initially breastfeed, or perhaps they weaned and now wish to reinstitute lactation, or even women who previously breastfed a biological child years ago and are now, say, adopting and want to breastfeed again.
Ah, I see.
The key difference from induced lactation is that their breasts have already undergone the changes of a prior pregnancy and lactation, which, can make the process somewhat easier.
What I find truly surprising about this whole topic is that it's not some cutting-edge modern discovery. Am I right in thinking these practices have, deep historical roots?
Oh, absolutely right. The true marvel isn't just that it's possible, but how ancient and, well, pervasive this capacity is. Historically, these practices were actually quite common in pre-industrialized societies and during times of disaster or epidemics.
Really? Like a survival thing?
Exactly. Think of it as a profound, ancient human capacity for survival and community care. For instance, Margaret Mead's observations in New Guinea back in 1935. She documented cases where women would relactate to care for and nourish motherless infants, highlighting it as a crucial survival tactic.
Wow. And yet it seems like for a long time in Western medical literature, it was sort of dismissed, often reported as aberrant lactation.
Yeah, that's true. It wasn't until more recent reports like Cohen's in 1971 that it really began to be discussed as an intentional, successful process with recognized protocols. And in modern contexts, the interest often stems from adoptive mothers who deeply desire to nurture their adopted children at the breast, even if they didn't carry them. Relactation, on the other hand, sees renewed interest from mothers of sick or premature infants who wish to reestablish breastfeeding after their babies have left the NICU, for example.
Got it.
Now, a crucial distinction for your IBCLC exam, and one that's often confused, is differentiating induced lactation and relactation from galactorrhea.
Right, that's important.
Galactorrhea, or inappropriate lactation, is typically pathological. It's often linked to underlying hormonal diseases like a prolactinoma, which is a benign tumor of the pituitary gland. Induced lactation, in contrast, is a deliberate, intentional process, usually achieved through specific protocols.
That distinction between intentionality and pathology is absolutely crucial for any aspiring IBCLC. It means recognizing the difference between, a natural, purposeful journey and a potential medical red flag.
Couldn't agree more. And this brings us to the fascinating biological blueprint that allows us to mimic pregnancy to achieve milk production. Okay, so in a typical pregnancy, the breast is naturally prepared by this intricate hormonal dance. You have high levels of progesterone and estrogen, mainly from the placenta, alongside prolactin from the pituitary gland, increasing throughout gestation. These hormones ready the breast tissue, promoting the growth of the milk-making lobulo-alveolar structures.
But the milk doesn't actually come in during pregnancy.
Right, exactly. Milk secretion itself is actually inhibited during pregnancy by those very high levels of estrogen, progesterone, and also placental lactogen. Placental lactogen acts as a natural prolactin-inhibiting hormone.
So after birth, the placenta is removed. those estrogen and progesterone levels plummet.
Right.
And that's the physiological signal. That allows prolactin to finally initiate full milk production.
Precisely.
The big question then becomes, how do we deliberately mimic this incredible process without an actual pregnancy?
That's the core of induced lactation. Protocols often involve prescribing oral contraceptive doses, things like orthonovum, ortho-135, or microgestin. These pills contain a combination of estrogen and progesterone.
Okay.
The key is they're taken continuously, only the active pills, to prime the breast tissue. The aim here is to induce specific breast changes, like increased size, fullness, and tenderness. These are vital signs that the milk-making apparatus is adequately growing, just like it would in early pregnancy.
And it's important to note, right, that the hormone levels in these birth control pills are actually minuscule compared to the massive surge of hormones during a full-term natural pregnancy.
Absolutely. So while it's mimicking the effect, it's not the same scale of hormonal exposure. A very important point.
Okay.
And crucially, these hormones must be discontinued before lactation is intended to begin, usually about a month prior. This allows prolactin's inhibitory brake to be released and milk synthesis can start.
Makes sense.
What's fascinating here is that animal studies, particularly with goats, have shown successful lactation induction using similar hormone combinations. When treated with estrogen-progesterone, goats develop udders and produce milk almost comparable to normal postpartum animals. It really underscores the deep physiological basis across species.
So we've got the hormonal mimicry to prep the breast, but what's the other vital piece of the puzzle for triggering milk production?
Mechanical stimulation. It's absolutely vital. This can involve various methods: systematic manual expression of the breasts, specific nipple stimulation exercises, or most effectively, using a good quality electric double breast pump. Often a hospital-grade pump is recommended for its efficacy.
And it's not just about doing it, it's about doing it systematically for the best results.
Exactly. Pumping typically starts gradually, maybe 5 minutes 3 times a day. Then you increase the frequency over time to, say, every 4 hours.
Okay.
And here's a pro tip for your exam prep. Often, it's recommended to include one pump session during the night, between 1 a.m. and 5 a.m.
Why then specifically?
Because that's when prolactin levels naturally rise, so you maximize the hormonal response. This consistent stimulation helps elevate both prolactin and oxytocin levels.
Oxytocin, that's for the letdown reflex.
Correct. While oxytocin is critical for the milk ejection reflex or letdown, studies have shown that using intranasal oxytocin doesn't necessarily increase the actual volume of milk produced. However, it can certainly instill confidence in the mother by facilitating that crucial letdown, which feels encouraging.
Right, that makes sense. Now, a common and I think very valid concern for anyone considering induced lactation is, what about the milk itself? Is it, normal compared to milk produced after a biological pregnancy?
That's a very important question, both for the mother and for you as the IBCLC supporting her. Studies in other species, like bovine and rat, and human observations suggest that induced milk is generally not significantly different from puerperal milk. That's the milk produced post-delivery, especially after the initial colostrum-like phase. Now, while some studies have shown slight differences, maybe in protein levels, from non-biologic mothers compared to biologic mothers, for the primary goal of nurturing, these differences are often considered less clinically significant.
But maybe more of a concern for vulnerable infants.
Exactly. A clinician needs to consider this for particularly vulnerable infants, like premature or small for gestational age babies. In such cases, a hematocrit test can be performed. This assesses the fat and energy content, providing more precise information for individualized care.
Oh, good to know.
This is a key point for your exam, knowing when and why to recommend additional assessment like a hematocrit.
Now that we've delved into the biological blueprint in the milk itself, let's talk about the specific toolkit, the pharmacologic and herbal agents used in this process, specifically the galactagogues, those agents designed to increase prolactin.
Right. One key pharmacologic agent often used is domperidone. It's primarily an antiemetic and anti-nausea drug, but it has the beneficial side effect of increasing prolactin levels. Crucially, domperidone typically does not cross the blood-brain barrier in significant amounts. This generally makes it safer in terms of neurological side effects compared to some alternatives like metoclopramide, which is also known as Reglan.
And for those of us in the U.S., there's often confusion around its availability. How is it typically accessed here versus other countries?
Yeah, that's a common question. Domperidone is widely available and approved for use in breastfeeding mothers by organizations like the American Academy of Pediatrics, the AAP, in many countries outside the U.S., like Canada. In the U.S., it's not FDA approved specifically for lactation purposes.
So how do people get it?
Well, it can be obtained from compounding pharmacies with a prescription, or it can be legally imported for personal use with specific documentation. You need a doctor's prescription and a statement of personal use, and you can't import more than a 3-month supply.
Got it. What's a typical dose?
The typical starting dosage is usually 10 milligrams 4 times a day for about a week. Then it's often increased to 20 milligrams 4 times a day. It's generally best taken about 30 minutes before meals and at least an hour before pumping or feeding for optimal absorption.
Are there side effects to watch for?
Side effects for the mother are generally mild things like dry mouth, headache, maybe some abdominal cramps. Rare cardiac arrhythmias have been reported, particularly at very high doses or with interacting drugs, so monitoring is important. Very low levels are reported in breast milk itself.
Okay. You mentioned metoclopramide or Reglan as an alternative. What's the key difference, and why is it generally less preferred for long-term use here?
The key difference is that metoclopramide, while also a dopamine antagonist that stimulates prolactin, does cross the blood-brain barrier. This means it can cause more significant neurological side effects for the mother. Things like sedation, anxiety, depression, or even extrapyramidal symptoms like involuntary movements. For these reasons, it's generally not recommended for long-term use, and the AAP classifies its effect on nursing infants as unknown or may be of concern. So, more caution there.
Makes sense. Are there other, perhaps less common pharmacologic agents that might come up?
It's interesting, yes. Beyond these more common agents, seemingly disparate drugs can act as galactagogues. For instance, chlorpromazine, which is an antipsychotic, can work by essentially lifting the brain's natural brake on prolactin release, what we call prolactin inhibitory factor, or PIF. It was even used historically in places like refugee camps.
Wow.
Theophylline, found in tea and coffee, can also increase prolactin, though too much might actually inhibit letdown. Thyrotropin-releasing hormone, TRH, that's a key pituitary hormone affecting thyroid-stimulating hormone. TSH2 stimulates both TSH and prolactin release. It's been used in relactation studies, though not widely for new induction. Even growth hormone, GH, can contribute to lobulo-alveolar development and casein expression, potentially optimizing milk production. And sulpiride is yet another dopamine antagonist that increases prolactin, similar to metoclopramide. It really underscores the brain's central role in all this.
So we've got these potent pharmaceuticals, but what about some more natural herbal allies that mothers might ask about?
Yes, common herbal adjuncts include fenugreek seed and blessed thistle herb. A typical dosage is often 3 capsules of each, 3 times a day with food.
Any side effects or cautions with those?
Fenugreek can sometimes cause a maple syrup or curry-like body odor, which is usually harmless but noticeable. It may also cause stomach upset, especially if taken too early in the process or on an empty stomach. And it's important for diabetics and asthmatics to use fenugreek with caution, as it can potentially affect blood sugar and breathing.
And at what point in the protocol are these herbs typically introduced?
Generally, herbs are introduced after the initial hormone or domperidone phase. Usually once pumping has begun and a baseline of milk production is being established, they're more like adjuncts. This really highlights that understanding the diverse mechanisms and potential side effects of all these agents, pharma and herbal, is paramount for IBCLCs. Not just for exam recall, but for safe and effective client counseling.
Absolutely. So now that we've grasped the agents, let's explore how they're actually put into practice with structured protocols and the essential practical management strategies for success. When we talk about induced lactation, the Newman-Goldfarb protocols are practically synonymous with systematic approaches, right?
Indeed. These protocols, developed by Dr. Jack Newman and Lenore Goldfarb, are widely recognized. They offer different versions depending on the lead time a mother has before the baby's arrival.
Okay, so let's break down the main ones. First, the regular protocol. What's that involve?
The regular protocol is ideal for mothers with a generous lead time, typically 6 months or more. It involves a prolonged period, often 6 months, on active birth control pills combined with domperidone. Then, the birth control pills are discontinued about 6 weeks before the baby's anticipated arrival. Domperidone is continued, and systematic pumping is initiated. This extended preparation allows for maximal breast development, which can lead to potentially higher milk production.
Okay, but what if someone doesn't have that much lead time? The baby is arriving sooner.
That's where the accelerated protocol comes in. It's designed for those with less time, say maybe 30 to 60 days of preparation. This protocol focuses on a shorter, intensive period of birth control pills and domperidone until what's called significant breast changes occur.
Ah, that phrase again.
Yes. Once those changes, like increased size, fullness, or tenderness, are observed, the birth control pills are stopped and pumping begins. While milk production might be lower than with the regular protocol because of the shorter prep time, it can still be significant and incredibly meaningful for the mother and baby.
And then there's a specific protocol for postmenopausal women. That seems like a unique consideration.
It is. The menopause protocol is tailored for postmenopausal women, whether it's natural or surgical menopause. It involves adjusting hormone replacement therapy to mimic pregnancy levels, combining it with domperidone, and staying on this combo for a minimum of 60 days. After that period, the hormones are discontinued and systematic pumping begins.
Okay, so across all these protocols, what's the most critical indicator? The thing that signals success or readiness?
Well, consistency in following the protocol is paramount, obviously, but that significant breast change we mentioned is a really crucial clinical indicator. It means the breast should increase in size, ideally by at least 1 cup size, and feel full, heavy, maybe even painful. That signals adequate growth of the milk-making apparatus.
And if those changes aren't happening?
That's a sign to reassess the protocol, maybe adjust dosages or check compliance. It's a key checkpoint.
Got it. Beyond the protocols themselves, what are some of the practical steps and crucial support systems needed to maximize success and support the mother's journey?
First and foremost, consistent nipple stimulation is critical. We talked about pumping.
Right, the frequency and the night pump.
Exactly. Whether it's manual expression or mechanical pumping with a high-quality electric pump, it needs to be frequent, ideally every 3 hours, including that dedicated night pump between 1 a.m. and 5 a.m. And efficient breast emptying is key to maintaining supply.
And what about diet and fluids? Any specific recommendations for someone inducing lactation?
Adequate caloric and fluid intake is essential, just like for any lactating mother, to maintain her energy and supply. While it's anecdotal, eating oatmeal regularly is often suggested by many people for milk production. And avoiding excessive caffeine is generally advised as it's a diuretic and can lead to, well, rapid fluid excretion.
Okay. When the baby finally arrives, how is feeding typically managed, especially if the milk supply isn't fully established yet, which must often be the case with induced lactation?
Right. Upon the baby's arrival, the mother should aim to breastfeed on demand, which usually means 10 to 16 times in 24 hours. A crucial tool here are supplemental nursing systems, or SNS devices.
Ah, yes, the SNS.
These allow the infant to receive supplementary milk, whether it's the mother's own stored milk, donor milk, or formula, while suckling at the breast. This is incredibly beneficial. It stimulates the mother's milk supply, helps the baby associate the breast with fullness, and ensures the infant gets adequate nourishment without the potential for nipple confusion that bottles can sometimes cause.
And the baby has to work for the milk from the SNS?
Yes, the devices are engineered, so milk is obtained by suckling, not just gravity flow. Gradually, the infant can be weaned from the supplementer as the mother's own supply increases. It's also usually recommended to avoid rubber nipples and pacifiers initially to encourage proper breast suckling. Other supplementation, if needed, can be given by dropper, spoon, or cup.
How should mothers store the milk they're pumping during this whole process?
Pumped milk should be stored ideally in 1-ounce portions in freezer bags, clearly dated. When frozen below 0 degrees Fahrenheit, or about an Ecostal 18 Celsius, it can be stored for up to a year, which provides a great backup supply or a way to build a stash.
Okay.
Beyond the mechanics and the hormones, there's a huge psychological component to this journey, wouldn't you say?
Absolutely.
The phrase breastfeeding is a confidence game truly rings true here. Relactation can often be psychologically easier if a woman has previously breastfed, as she has that past experience, that body memory to draw upon. Supporting the mother emotionally, avoiding undue stress about milk volume, and really focusing on the nurturing relationship that breastfeeding provides are paramount for success.
And what about professional support? What kind of team should mothers ideally lean on for this unique journey?
The role of a licensed, board-certified lactation consultant, an IBCLC like you, is invaluable for that day-to-day guidance, ensuring proper latch, troubleshooting issues. Physician support is also critical, especially for monitoring the infant's growth to ensure adequate nutrition and addressing any underlying health concerns for the mother herself. It's a team effort.
You mentioned relactation earlier as generally easier than de novo induced lactation. Any other specific insights there for an IBCLC?
Yeah, relactation is indeed generally considered easier, particularly if the breast has been previously primed by pregnancy and lactation. Success has been reported even in crisis situations and for mothers of older children. It highlights the breast's amazing ability to remember its function and reestablish supply, sometimes even years later.
That's incredible. Now, one very important counseling point for IBCLCs, especially when mothers are on these continuous birth control pill protocols, relates to contraception. Is the continuous use of these DCPs reliable for preventing pregnancy during induced lactation?
That's a critical point for IBCLCs to counsel on. The continuous use of birth control pills for induced lactation does not provide standard contraceptive protection.
Why not?
Because they are taken nonstop, regardless of the woman's natural cycle, and often for a purpose other than contraception. Breakthrough bleeding is actually a common symptom. Therefore, alternative non-hormonal contraception is highly recommended if pregnancy avoidance is desired. It's a key safety and counseling point you need to cover.
Definitely noted.
And while it's a slightly distinct topic, the sources also touch on cross-nursing, sometimes called co-feeding. That's where a woman nurses a non-biological child. Historically, this was a common practice. But in contemporary society, it carries risks, obviously, like the transmission of infections such as HIV, unless very careful precautions and screening are taken. In certain specific controlled settings, it might be used perhaps to stimulate a mother's supply or teach an infant to suckle, but always with extreme caution and appropriate medical screening.
Okay. Now that we've thoroughly explored this fascinating world of induced lactation and relactation from its deep history to the science and practical protocols, let's bring it all back to your goal, mastering the IBCLC exam.
Yes. When we connect this to the bigger picture, the exam won't just ask for simple definitions. It will test your ability to synthesize this information and apply it to real-world scenarios. We want to discuss how these concepts might actually appear in multiple-choice questions you might face.
Right. Imagine a question on the exam presenting a scenario. A mother comes to you expressing interest in breastfeeding an adopted baby, but she's never been pregnant. You would need to correctly distinguish between induced lactation, relactation, and galactorrhea to properly assess her needs and guide her.
Or perhaps a question might ask you to identify the appropriate pharmacologic agents and their mechanisms of action. For instance, how domperidone increases prolactin versus why metoclopramide is generally less preferred due to its potential neurological side effects crossing the blood-brain barrier.
Yeah, knowing the why behind the recommendations.
Exactly. You might also encounter questions testing your understanding of the proper sequence and timing of, say, the Newman-Goldfarb protocols. This means knowing when to advise stopping the birth control pills, when to initiate systematic pumping, and crucially, recognizing those significant breast changes as that key protocol indicator.
Or maybe a troubleshooting question.
Precisely. A question could present a mother who started a protocol but isn't seeing results. You would need to apply your knowledge of dosages, timing, potential issues like lack of those breast changes or maybe inconsistent pumping to figure out the next best step.
Absolutely. The exam isn't just about rote memorization. It's about applying this knowledge to counseling scenarios. Picture an adoptive mother worried about the composition of her induced milk. How would you counsel her on the clinical significance of any potential differences, especially for a healthy full-term infant, versus the broader nurturing goal?
Right, or a mother struggling with supply, or maybe an issue with a baby's latch and the effective use of a supplemental nursing system. How would you guide her through troubleshooting that? What are the key steps?
This raises another important question type. How would you counsel a mother on the benefits of even a partial milk supply? Given what we know about milk composition in induced lactation versus the broader nurturing and bonding goals, the exam might challenge you to think beyond just milk volume and consider the significant emotional and developmental benefits for both the infant and the mother.
So when you're faced with these kinds of questions on your IBCLC exam, remember to critically think, identify the key information in the scenario, sift through the details, and select the best course of action based on the detailed content we've covered in this deep dive. Your role is really to be that comprehensive, knowledgeable guide. So we've covered the nuances of induced lactation and relactation today. From their fascinating historical roots to the detailed modern protocols, the incredible science behind the milk itself, and the array of pharmacological and herbal supports available. It's quite a landscape. It really is. And this knowledge isn't just for passing an exam, is it? It empowers you to truly support diverse families on their unique breastfeeding journeys, offering truly tailored, evidence-based care in a field that continues to expand our understanding of human physiology and, well, nurturing.
Which leads to a final thought. Considering the profound impact that induced lactation and relactation can have on forming that mother-infant bond, how might our understanding of motherhood itself continue to evolve in light of these incredible possibilities? Something to ponder.
Absolutely. Continue to explore this impactful field and the many ways we can support every family's feeding goals.
And today, this deep dive is specifically crafted for you, especially if you're preparing for the IBCLC exam. We've got 15 multiple choice questions lined up.
Right, exam style. And we're going to unpack the answers, drawing insights straight from the latest research and protocols.
Yeah, it's about getting to the core of what you absolutely need to know. Might even be some surprising facts and definitely practical applications for those tricky exam questions.
Our mission today is to pull out those key nuggets of knowledge from the resources, help you grasp the nuances of induced lactation and relactation. I'll be asking the questions, setting the scene.
And I'll be connecting the dots, offering that bit of broader context and maybe some deeper understanding based on the materials. Ready to jump in?
Let's do it. First things first, getting those basic definitions straight. It sounds simple, but this is often where key distinctions lie, right?
Absolutely foundational.
Okay, question one. Let's get this core difference nailed down.
What is the primary distinction between induced lactation and relactation as defined in the provided resources? A. Induced lactation refers to breastfeeding a baby born via surrogacy, while relactation is for adopted babies. B. Induced lactation is the process by which a non-peripheral woman is stimulated to lactate, whereas relactation involves a woman who has previously given birth but did not initially breastfeed or chooses to reinstitute lactation. C. Induced lactation requires hormonal preparation, while relactation only requires nipple stimulation. D. Relactation always results in a full milk supply, but induced lactation often does not.
Okay, the correct answer here is B. The sources are really clear. Induced lactation is specifically for a non-puerperal woman, meaning someone who hasn't recently been pregnant being stimulated to lactate.
So that could be an adoptive mother or maybe an intended parent using surrogacy, someone without that immediate postpartum hormonal environment.
Exactly. And relactation, that's different. It applies to women who have given birth before. Maybe they didn't breastfeed right away, or they weaned and want to start again, or perhaps they breastfed a biological child years ago and are now adopting.
So the history of pregnancy is the key differentiator there.
It really is. That prior experience physiologically changes the starting point. It's a fundamental difference you need to grasp for the exam and for how you'd approach supporting these families. It shapes the whole process and what expectations are realistic.
Makes total sense.
Yeah.
Knowing that baseline is vital. Okay, definitions down. Now, how solid is the science behind all this? Let's look at the research landscape.
Based on the provided resources, what is the current state of blinded, controlled research studies regarding induced lactation and relactation in humans? A. There are numerous robust clinical trials confirming their efficacy. B. The literature is extensive, with many randomized controlled trials. C. There are no blinded controlled research studies, and the literature is meager, predominantly in animal research. D. Clinical trials have confirmed the process for most diets.
All right, for this one, the answer you need to know is C. The sources pull no punches here. They state, quite directly, there are no blinded controlled research studies about either induced lactation or relactation.
Wow, none. So what do we have then?
Well, it says there are occasional observation reports about successes in a small series of diets, but importantly, the process has not been confirmed by clinical trials. The literature is actually meager and predominantly in the animal research field.
That's quite striking. So even though people do this and we see success stories, that gold standard evidence, the big clinical trials, just isn't there for humans?
Pretty much. And that's a huge takeaway for anyone preparing for the IBCLC exam or practicing. It means your guidance relies heavily on protocols developed from, observational data, animal studies, and clinical experience, rather than large randomized controlled trials.
So it becomes even more about individualized care and managing expectations carefully.
Precisely. Informed consent becomes critical, explaining what we do know and what research is still lacking. It's not just following a recipe, it's navigating based on the available, albeit limited, evidence.
Okay, that's a really important point about evidence-based practice. Now, sometimes lactation happens when it's not intended. Let's clarify that.
When a non-pregnant woman spontaneously develops lactation, galactorrhea, What is the most common underlying cause that requires medical evaluation? A. Insufficient nipple stimulation. B. A prolactinoma of the pituitary. C. Excessive consumption of galactagogues. D. Residual hormones from a past pregnancy.
The answer here is B, a prolactinoma of the pituitary. Our sources make a clear distinction. Induced lactation is purposeful. Galactorrhea, or spontaneous lactation in a non-pregnant, non-lactating woman, is considered inappropriate lactation.
So if someone just starts producing milk out of the blue and they weren't trying to, that's not induced lactation. That's a signal to see a doctor.
Absolutely. The text says, a non-pregnant woman who develops spontaneous lactation should be evaluated for hormonal disease. The most common cause is a prolactinoma of the pituitary. Spontaneous lactation should not be ignored.
That's a critical piece of knowledge for an IBCLC, right?
Yeah.
Knowing when to refer for medical assessment versus supporting an intentional lactation process.
Definitely. You need to recognize those red flags.
Okay, so we know spontaneous lactation needs investigation. But how do we figure out how to intentionally induce it, especially using hormones? Turns out, animal studies gave us some clues.
In animal studies cited, particularly with ovary-ectomized goats, which combination of hormones resulted in better milk yield and normal histological lobulo-alveolar growth when inducing lactation. A. Prolactin alone. B. Estrogen alone. C. Estrogen and progesterone. D. Growth hormone and thyroid hormone.
This one points to C. Estrogen and progesterone. The sources mention these goat experiments where, yeah, estrogen alone caused some utter development.
But it wasn't ideal.
Right. It was the combination of estrogen and progesterone that led to better milk yield and physiologically normal development of the milk-making structures, the lobulo-alveolar growth. Estrogen alone apparently resulted in cystic and irregular growth.
So that combination is key for getting the breast tissue truly ready, mimicking what happens naturally in pregnancy.
Exactly. It's foundational science that informs the hormonal priming parts of human protocols like Newman-Goldfarb. You're trying to build the factory properly before you turn it on.
Building the factory, I like that analogy. Okay, speaking of protocols, let's look at the Newman-Goldfarb one. Specifically, it's mentioned a lot.
According to the Newman-Goldfarb regular protocol for induced lactation, what is the ideal recommended duration a mother should be on the combined birth control pill and domperidone therapy before stopping the birth control pill and beginning pumping? A. 1 month. B. 3 months. C. 6 to 9 months. D. Until milk drops appear.
According to the protocol described in our sources, the ideal time is C, 6 to 9 months.
6 to 9 months. That's a significant lead time before the baby arrives. Why so long?
Well, the protocol states, for this reason, 6 to 9 months on the combination of the birth control pill and domperidone before baby is expected to arrive produces the best results. The rationale given is that the longer the time a mother spends inducing lactation, the longer the milk-making apparatus of her breast will have time to prepare.
So it's really leaning into that mimicking pregnancy idea, giving the body maximum time to develop those milk-producing structures we just talked about.
Precisely. It's about optimizing the preparation phase for potentially better outcomes later.
Understood. Now, hormones, protocols, they can seem complicated, but what's the absolute rock-bottom essential? What has to happen?
What is the only absolutely necessary component to induce lactation, regardless of whether medications or herbs are used? A. Hormone therapy with estrogen and progesterone. B. Consistent use of a pharmaceutical galactagogue. C. Frequent and effective stimulation and drainage of the breasts. D. A history of previous pregnancies.
This is a crucial one. The answer is C. Frequent and effective stimulation and drainage of the breasts.
So all the other stuff, the hormones, the herbs, they can help, but they aren't the fundamental trigger.
Exactly. The sources state it clearly. The only necessary component to induce lactation is to stimulate and drain the breasts, whether that's the baby nursing, a pump, or even a hand expression.
That really boils down to the core principle of lactation, doesn't it? Supply and demand. Remove the milk, stimulate the breast, and the body responds.
It does. Medications and hormones can, enhance the process, potentially increase the supply significantly, but the physical act of stimulation and emptying is the engine driving it all. It's essential information for you to share with families.
Absolutely empowering knowledge. Okay, let's talk more about those helpers, the galactagogues. Specifically, pharmaceuticals and their safety.
Which pharmaceutical galactagogue is noted in the sources as generally safer than metoclopramide because it is not known to cross the blood-brain barrier in significant amounts, thereby reducing the risk of neurological side effects? A. Chlorpromazine. B. Thyrotropin-releasing hormone, TRH. C. domperidone. D, sulpiride.
The one highlighted for its better safety profile in this regard is C, domperidone.
And the key reason is that blood-brain barrier thing.
Yeah. The sources compare it directly to metoclopramide, or Reglan. They say domperidone is not known to cross the blood-brain barrier in significant amounts, making it less likely to cause side effects like depression or neurological issues. It's considered much safer for mother and baby in that respect.
Whereas metoclopramide does cross that barrier.
Yes, the sources note metoclopramide crosses the blood-brain barrier and can cause neurological problems and depression. So that difference in how they interact with the central nervous system is a really key distinction for an IBCLC to know when discussing options.
Definitely a major point for counseling. Now, shifting to practical application at the breast, especially when supplements are needed, how do you use those devices optimally?
When using a supplementary feeding device like the Lactate or SNS while establishing a milk supply, what is the recommended practice to maximize the mother's own milk production? A, fill the device with artificial infant milk exclusively to ensure adequate nourishment. B, allow the baby to feed with the supplementer flowing from the start of the feeding on both breasts. C, allow the baby to feed on each breast with the supplementer in place but not flowing until the baby stops drinking, then allow the supplement to flow. D, limit breast contact to only a few minutes before offering the device.
The best practice described is C. You let the baby feed on the first breast with the device there, but the tube clamped or pinched off, so not flowing.
So baby works the breast first, gets whatever milk is there, provides that crucial stimulation.
Exactly. The advice is to let the baby feed like that, maybe use breast compression to help, until the baby stops actively drinking. Then switch to the other breast and do the same thing.
And only after the baby has worked both breasts, then you let the supplement flow.
Right. The mother should allow the supplement to flow only when the baby has done both sides at least. This maximizes the stimulation and milk removal from the mother's own supply before the supplement comes in. It reinforces that supply and demand loop.
That makes so much sense. Prioritize the breast. Okay, another specific scenario. Tandem nursing, but in an adoptive context.
In tandem nursing, when an adoptive mother is simultaneously nursing an older biologic child and a newly adopted infant, what is unique about the milk composition for the adopted infant compared to a situation involving a new biologic pregnancy? A, the milk will revert to colostrum-like composition for the adopted infant. B, the milk volume will decrease significantly due to sharing. C, the milk volume may increase with increased nipple stimulation, but the constituents will not change to colostrum-like. D, the milk will be nutritionally insufficient for the adopted infant.
The unique point here is C. When a mother gives birth again while nursing an older child biologic tandem nursing, the milk usually reverts to that colostrum-like state for the newborn.
But that doesn't happen without a new pregnancy.
Correct. The sources state, in the absence of a pregnancy, however, the milk volume may increase with increased nipple stimulus while the constituents do not change. So the milk stays mature milk, even if there's more of it, due to the increased demand from two babies.
So no automatic reset to colostrum for the adopted baby in that situation. That's a subtle but important difference for an IBCLC to know.
Very important for managing expectations and nutritional planning, yes.
Okay, back to the Newman-Goldfarb protocols. We know they recommend hormonal priming, but what if someone can't take the standard combo pill, say, if they're over 35?
For women over the age of 35 who are following the Newman-Goldfarb protocols for induced lactation and are unable to use the estrogen-progesterone combination birth control pill due to health risks, what alternative progesterone-based medication is suggested to prepare the breasts? A, Aldomet. B, Zoloft. C, Provera 2.5 or Prometrium 100 milligrams. D, oxytocin nasal spray.
The suggested alternative in the protocols is C, Provera 2.5 milligram or Prometrium 100 milligram.
So it's a progesterone-only option to replace the combined pill.
Yes. The protocol explicitly says if you're over 35 or can't use the combined pill, kindly replace the microgestin or Ortho 135 with Provera 2.5 or Prometrium 100 milligrams.
That shows some built-in flexibility, adapting the protocol for different health profiles or risk factors.
It does. It acknowledges that a one-size-fits-all approach doesn't work, especially when dealing with hormones and potential contraindications, like history of clots or certain health conditions more common in older women. It's about finding a safer way to achieve that necessary breast preparation.
Good to know there are documented alternatives. Now let's revisit relactation, specifically in the NICU setting. There was a study mentioned by Bose et al. About challenges mothers faced.
In the study by Bose et al. On relactation among mothers of sick and premature infants in the NICU, what was identified as the most significant factor impacting mothers' ability to initiate suckling? A, the degree of infant prematurity. B, the infant's postnatal age or weight. C, the length of separation from their infants. D, the feeding regimen prior to the study.
The study found the most significant factor was C, the length of separation from their infant.
Really? More significant than how premature the baby was or how much they weighed?
Apparently so. The source notes that while initiating suckling was difficult for many, the most significant factor being the length of separation from their infants, and not the degree of prematurity, postnatal age, weight, or feeding regimen.
That speaks volumes about the psychological impact, doesn't it? The stress and the practical difficulty of establishing that connection when separated.
It really does. For an IBCLC and an NICU, it highlights how crucial facilitating contact skin to skin and minimizing that separation time is, not just for bonding, but for the practical success of getting breastfeeding or relactation started. It's a powerful barrier.
A very human factor. Okay, let's dig back into the physiology behind the Newman-Goldfarb pumping schedule. Why pump so often and at specific times?
The Newman-Goldfarb protocols for induced lactation leverage, a specific physiological principle regarding serum prolactin levels and pumping. Which principle is this? A, prolactin levels are highest in the afternoon, so pumping should be focused then. B, frequent breast emptying is more influential on milk supply than the duration of breast emptying, and prolactin levels naturally rise between 1 a.m. and 5 a.m. C, pumping should only occur when prolactin levels are at their lowest to prevent oversupply. D, serum prolactin levels are solely determined by medication intake and unaffected by pumping.
The principle they leverage is B. Two key things here. First, a mother's serum prolactin levels naturally rise between 1 a.m. and 5 a.m. Pumping then takes advantage of this peak.
Okay, so work with the body's natural hormone rhythm. And the second part?
The second part is that research has shown that frequency of breast emptying is more influential on milk supply than duration of breast emptying.
So hitting those high prolactin times and emphasizing frequent, regular emptying, even if sessions aren't super long, is the strategy.
Exactly. It's a combination. Leverage the natural hormonal peaks, especially overnight, and prioritize frequency of stimulation to drive supply. Understanding that why can really help you explain the importance of the pumping schedule to clients.
Absolutely. Knowing the rationale helps adherence. Now, besides pharmaceuticals, herbal galactagogues are also mentioned, but with caveats.
Which herbal galactagogue mentioned in the Newman-Goldfarb protocols requires caution for diabetic mothers due to its reported effect on serum glucose levels. A, blessed thistle. B, fenugreek. C, silymarin. D, coconut milk.
The one requiring caution for diabetic mothers is B, fenugreek.
Because it can affect blood sugar.
Yes, the sources explicitly warn fenugreek has been reported to affect serum glucose levels. Therefore, diabetic mothers are advised to use this herb with caution.
That's a critical safety point. Any other cautions mentioned for fenugreek?
Yes, the source also notes it can aggravate asthmatic symptoms, so caution is needed for mothers with asthma too.
Okay, so important to get that health history. It really underscores that even natural remedies need careful consideration based on the individual's health.
Absolutely. Always.
Let's touch on an ethical issue that sometimes comes up: access to care.
In a reported case involving a physician refusing to assist a patient in a same-sex couple with induced lactation, what was the conclusion of the ethics consultation? A, the physician's refusal was justified due to the medical complexities. B, the physician's objections were unfounded, as the value to the infant outweighed any objections. C, induced lactation is generally not recommended for same-sex couples. D, the case was deemed unresolvable due to conflicting viewpoints.
The conclusion reported in the sources was B. The physician's objections were unfounded.
And the reasoning?
The ethics consult felt the value to the infant was paramount and outweighed the objections. It also suggested the refusal showed a troubling unfamiliarity with the clinical facts of lactation, a double standard for treating LGBTQ patients and heterosexual patients.
So the ethical stance supports providing care and information equitably, focusing on the infant's well-being, regardless of the family structure.
That's the takeaway. It highlights the professional responsibility to provide unbiased, evidence-informed care and support to all families seeking to lactate or breastfeed.
A crucial principle.
Yeah.
Okay, last question, bringing it back to the basics of observing breastfeeding. How do you know the baby is actually getting milk?
According to Dr. Newman's description, what does the suck, pause, suck pattern at the breast indicate regarding milk transfer? A, the baby is falling asleep at the breast. B, the baby is inefficiently suckling without milk transfer. C, the pause in the chin after opening to maximum before closing represents a mouthful of milk. D, The baby is about to unlatch from the breast.
Dr. Newman's description points to C, that distinct pause of the chin at the widest point of the suck before closing the mouth. That's the indicator.
So it's not just sucking movements, but that specific open pause, close rhythm.
Exactly. He describes it as open mouth, wide pause, close mouth. He even gives that analogy of sucking on a straw. Your chin stays down while you're drawing fluid in. That pause at the breast signifies the baby getting a mouthful of milk.
And a longer pause means more milk.
The longer the pause, the more the baby got. It's a really practical, observable sign of effective milk transfer, fundamental for any IBCLC's assessment skills.
Fantastic. A tangible thing to look for. And Hugh, that's our 15 questions. We've really taken a deep dive into induced lactation and relactation, hitting key points you'll want to know for the IBCLC exam.
Yeah, from those core definitions and the state of the research, right through to hormonal protocols, practical tips like using supplementers, and those crucial safety and ethical points.
We've unpacked a lot of those essential nuggets.
And it's important to circle back to something the sources emphasize. There is more to breastfeeding than breast milk. Even if inducing or relactating doesn't result in a full supply, the act itself, the closeness, the bonding, the relationship, that's incredibly valuable.
Absolutely. Milk volume is just one piece. This whole deep dive really shows the adaptability of the body and the different ways nurturing can happen, doesn't it? With dedication, good planning, and the right support.
The possibility of breastfeeding can open up for many different families in diverse situations. It's pretty amazing.
It truly is. So as you, our listener, reflect on all this, the physiology, the support, the personal journeys, here's something to think about. In what unexpected ways might our growing understanding of the body and the importance of psychological support continue to expand how we think about nurturing and feeding for all families in the future?